we'll go ahead and get started. I want to make sure everyone's time is very valuable. So thank you all for joining us today. We did add an extra clinical trials toolkit series to our series for this semester. So thank you all for joining us. I am Debbie Lee. I am the Assistant Director for our iScore RC, also training manager for the Center of Excellence as well. So you know what I'm going to say in the next 2 minutes. For attendance purposes, if you don't have your full name in your chat box on Zoom, you could just put your name in the chat for attendance purposes. We will be offering continuing education credits today. If you would like potential credit for ACRP or for SOCRA, if you just put CE or ACRP or SOCRA, I will get either the form over to you to fill out for continuing education credits, or Tyler is kind enough, he's going to provide his slides, and I will do our sign-in sheet for potential, sorry, I'm multitasking, obviously, but I'm letting people in the room, for potential credits. All right, with that, I think we will, give me 1 second. I see one person still connecting to audio. All right, they are connected. So thank you for joining today. We have the pleasure of Dr. Tyler McGahey. He comes to us from CTSI. He's with our Biostats, Epidemiology, and Research Design Core. His expertise will help us learn how to develop more robust slides for the benefits of patients. He is the research imaging specialist with a particular focus on human neuroimaging. He received his PhD from WVU in neuroscience in the lab with Dr. Victor Fenimore at Rockefeller Neuroscience Institute. He's also from Virginia and received his bachelor's degree from Hampton-Sydney College. In his free time, when he isn't hanging out with his wife and 2 cats, he is a C3 paramedic. So with that, I'm going to pass it over to Tyler.
Thanks, Debbie Lee, and welcome everybody. Go ahead and get these slides moving. There we go. If you have any questions, please stop me at any time. There is no such thing as a stupid question. And my general disclaimer, when I say something that is incorrect, because I probably will, please refer back to state, federal, and local policies. A good defense is not Tyler said it. You need to go with whatever the policy says. I'm just going to give you some general tidbits and best practices when we're working with data. So, what is InfoSecurity, or all the cool kids call it InfoSec? It's kind of a robust, multi-prong approach to protecting our patients by protecting their data. There's a combination of physical safeguards that we'll talk about, policy safeguards, and some good habits that we'll develop. So like I said, diving into this a little bit more, we're going to look at some application security, and this isn't my McDonald's application. This is going to be computer applications like Citrix and other secure network aspects. Infrastructure security, information security is partially IT's responsibility for making sure the network is secure. It's our responsibility as end users to make sure we're operating in secure manners by making sure we protect our data appropriately. We'll talk about cryptography, specifically 256-bit encryption, and some risk management strategy. So, what are some things that govern info security? This is most applicable to us in the healthcare patient research realm. We live and die by HIPAA. There's also some local state laws, and of course, our institutional policies, whether you are on the medicine side or the university side. And lastly, depending on where you're working or what you're working on, there may be some sponsor-initiated policy or regulation you have to follow. I want to touch on that a little bit. We do need to follow the sponsor's rules because in most cases, they are the owner of the data. And they are giving us a significant investment in time and resources in order to carry out that trial. And there's quite a few other stakeholders in the data. This can be the sponsor, the IRB, the study participants. And so we need to protect every entity that we work with. So That should be 1996. That's a typo. What is HIPAA? HIPAA is the Health Insurance Portability and Accountability Act. It governs what we can disclose about healthcare information, who can have it, when they can have it, and it's kind of the go-to standard. This is updated pretty regularly by HHS, Health and Human Services. So if you have any questions, they have lots of useful guides on their website, and I'd point you there for absolute governance. So more importantly, why should we care? Not only is it our responsibility to protect our patients and their privacy, you personally can face criminal prosecution and civil prosecution depending on the type of violation, on the scale, and whether you were negligent in your breach or exposure. So it is important to remember this isn't just data on a page. These are actual people, and these breaches can have actual impacts on folks. So what are the 18 HIPAA identifiers? This is a complete list that it's mostly self-explanatory. We're going to dive into a couple nuances here and there. The big one that I care about or deal with the most, we don't think about, are these facial images. The law is technically full facial images or comparable images. And so us in the healthcare space, I'll show you a good example of how we can get comparable images of a patient from their high quality scans. And the vehicle identifiers is another weird one because it actually includes VIN and license plate and a couple other things. So HIPAA data. What is HIPAA data? Any data set with at least one identifier is considered identifiable data. We must use an appropriate device and work in a secure space. Those are the general principles we're going to go over. We're going to dive into these a little more in depth. So what's a secure space? Like I said earlier, this is a multi-pronged approach to protecting our patients and their data. So this is kind of like a generic ED bed curtain situation. It's going to be harder to protect patient data, but when we're working with data here, it's a lot lower in scale. And so like if another patient in the next way over hears something that's considered an accidental or incidental exposure, but you're not leaking hundreds and hundreds of patients' data. And so when we work with these bigger data sets that involve hundreds or thousands of patients, we need to think about think about the space we're working in, thinking about a personnel who's accessing the data and working with the data, and who's around us. This is where I encourage you to follow the clear screen and clear desk policy. So this doesn't mean your desk needs to be junk free. As you can see behind me, I have all kinds of knickknacks. That's not the point here. The point is that you don't leave sensitive information out, whether you're going out to lunch, whether you're leaving for the day, protect your information. And so this can be as simple as having that catch-all drawer in your filing cabinet if you lock on the way out, making sure your office building locks, using those key card swipes and not just propping the door open. The other thing is to clear screen. One of the things that's really easy to get and find are the tinted screen privacy protectors. If your office doesn't already provide those, I'm more than happy to help you write a letter of justification. If not, they're only a couple bucks to go and buy for yourself. If you're not familiar with them, it's just a clear film that goes over your screen. As long as you're within 30 degrees either direction, your screen looks normal, but it prevents incidental exposures from long distance and from the edges. And that's important when you work in an open space like I do with lots of amounts of PHI. The other thing is, what's a secure device? So when possible, we want to use our work computer for work. I know this seems kind of basic, but if at all possible, we want to avoid having that protected health information outside of what we call the enterprise. And so we want to use our managed devices, so that hospital computer, that hospital laptop, our work computer, things like that, because they have what we refer to as the sniffers. They have SOFOs, they have Imprivata, they have two-factor authentication, and their entire hard drive's encrypted. There are some bring your own device policies, especially coming out of the pandemic. But when possible, we try to get you a managed device. And I'm happy to sit down and discuss with anybody on a case-by-case basis on how to set that up. And the other big thing is there's more than one way to lock your screen. Debbie Lee funnily asked me, are you going to talk about locking your screen? With our work computers, it's absolutely mandatory. They auto lock after so much time. You shouldn't be able to disable that. That's a managed security setting. But you should lock your screen even if you're walking away to grab a coffee or something like that. And if you want to go for it, you can go for it like in this meme. So now that we've kind of talked about some secure locations and secure devices, data in one place isn't practical or even the best practice. So here are some of the secure transfer methods. We're going to talk about data in two states, data in transfer and data at rest. And they have different policies and different safeguards, and they mean exactly like they sound. So data in transfer is when I'm transferring data from myself to someone else. So like if Carrie's my co-I, and I need to send her some patient data, there's a couple different ways I can do it. Since Carrie and I are both on the HSC side, we're within the same enterprise or company, I can send her a secure encrypted email with my PHI. You can either go up to the top of your email and toggle on the encryption setting, or you can do bracket, just like I have here, secure close bracket. This auto triggers the encryption algorithm, and it'll send it back and forth. If you need to send it outside of the organization, please refer back to your CTA or your DUA, your clinical trial agreement or your data use agreement. That is the exact method you should use. But a good example for us is Globus. Globus is an improved data transfer method for PHI. Another good way to transfer data, especially here around the HSC, is the secure network drives. We refer to them a lot by their mapping path, the Y drives. And these have secure physical safeguards and encryption methods. The big thing with all of these is they're encrypted, which we'll talk about, and we have audit logs available. So what is encryption? Encryption is basically turning things to gibberish. And you can't turn the gibberish back unless you have that secure encryption key. I know all of us in grade school did the A is actually 7 kind of thing. That's all this is, just on a higher standard. So our current standard developed by the NSA, National Security Agency, is 256-bit encryption. And if anybody can tell me what 256-bit encryption is without Googling it, I'll buy you a coffee. But what this is each character has 256 possibilities. And so if we do 256 factorial, it comes out to umpteen thousand different possibilities for a message. And so something just as simple as "Hi, Mom," like this text, would come out into this ciphertext like this. And there's no way to unencrypt it without that secure encryption key. And so that's our current standard. So that's what we use, or what we say when things are encrypted. And then what are audit logs? I call audit logs that nosy neighbor. This is the best security system out there. Not necessarily having a nosy neighbor sit there and watch a server, but access logs or audit logs let us see who accessed the data, what did they access, what they do with it, when did they do with it, how long did they use. And that's why we need to use approved transfer method. They have the nosy neighbor there for IT. We can see who did what, when, and what they're doing with it. So that's a whole lot of complicated things, and that seems like a headache to deal with. Making sure I'm on the network and logged in correctly just to access some data to then have to encrypt it and send it somewhere else. Is there an easier way to work with this data? Good news is yes. There's some de-identification methods, which we'll cover. We can talk about limited data sets, which is where we remove a lot of the identifiers we don't need. And we can create a coded data set where we create a secure crosswalk. That crosswalk is exactly what it sounds like. It lets us go back and forth between that code and the actual identifier. So there are two de-identification methods that are recognized as standard or common. Safe harbor is just a fancy word for saying we remove all of those 18 identifiers from the data set, and there's no way to link it back to the patient. And then the other one is when not used nearly as much, because you have to find a stats nerd or a data nerd like myself to help you out. So this is where we come in and do a lot of fancy math and some scientific principles to figure out if the data could be reasonably linked back to a person. And so, like the example I give is um, if I wanted to do an X-ray study and keep the data service on it, it's probably fine. Who knows how many X-rays were taken in the WV medicine system yesterday? There's no reasonable way to identify an X-ray with a data service of 6/20/2024 and a broken arm back to an individual. There's no way that an average person could do that because yesterday at WV medicine there was probably 100 different broken arms. And so that's where folks like myself or other folks in our biostats, bioinformatics group can help you de-identify data. Um, we don't routinely do this because there is a lot of work involved. One, two, it's also not as secure or exact, and it opens the expert up to a lot of liability. Because if they're wrong, there's a lot at risk. And so our preferred method is the safe harbor method. Does anybody have any questions so far? Anything I can clarify or answer? Okay, we will keep trucking.
Wait, Tyler, do you have a question from
Oh,
Yvonne? She said, I was under the impression that all emails sent internally to WVUM, HSC, etc., email addresses are automatically secure without entering the parentheses in the subject line, parentheses with the word secure.
that is something I'll have to double check. I'm not sure if it goes across enterprise because technically WVU, HSC, and W Medicine are different enterprises. I will have to look into that and follow back.
Okay, thank you.
So this, anybody good guess on who this might be? If you've seen one of my talks recently, you'll know exactly who this is. Somebody want to shout out or drop it in the chat.
Wes.
Yeah, this is good old Mr. Wes Kimball. First of all, this image was used with explicit consent, and he knows we're using this for different teaching purposes. But this is what I mean by a full face comparable image. So this is not a picture of Wes. This is a 3D reconstruction from a test MRI we took on. And so this takes all of, I don't know, 30 seconds worth of coding. And from those 2D slices, we can build this reconstruction. And so when we go through and de-identify data, that's something we have to think about. We actually remove the center part of that image and makes it a lot harder to re-identify that person. So now if I just showed you this forehead, even though there are some distinctive wrinkles on it, it'd be pretty hard to figure out that this is Wes. And so this is where you should really loop in your biostatistician or your data team to help you fully de-identify images or any other part of your data set. It's not just removing the patient's name and date of birth from the scan file name. Another thing we can do is called secure date shift. And so this is what I meant earlier by like a coded data set. And so most folks think like we can make Debbie Lee patient A01 and Carrie patient B01, etc. We can also apply this to other data elements. And so like this is a great example of a date shift. So the patient was born on May 5th, 1990, and we took their MRI on June 1st, 2020. We can shift both dates by the same amount and keep those important factors in the middle, like age at the date of scan, like if this was their diagnosis scan, but protect their identity by shifting these date of birth and data service and things like that. So it's important to remember that age under 89 years old is not an identifier, but things like date of birth and data service are. And so that's where it's a great idea to grab one of our data team to help you figure these things out. One last thing I want to hit on is what are the different classes of information? There's a handout that I've sent to Debbie Lee. Debbie Lee is going to send it out with the evaluation. And there are different classes of information to talk about. PHI or protected health information and research health information, RHI, are the most common data categories we talk about. The big thing is where the data comes from. The big difference here is PHI, protected health information, is coming from the medical record. Research health information may be related to healthcare, but it's not from the medical record. So an example here would be, did I get patient weight from a chart? Did I get patient weight from self-report? And there's benefits there that we can talk about, but this information has different standards. And so just really quick, the Office of Human Rights Protection puts out the super great handout um, that I'll send to you guys. And then the last category we need to talk about is PII, personally identifiable information. And so this is, again, identifiable information like name, but not from a healthcare field or healthcare setting. Um, and so, like I said, I will send this handout to you. It's also available from the Office of Human Rights Protection. Most of us keep this by our desks, and it helps you understand what category the data falls into and whether it's considered sensitive or confidential and things like that, depending on where it comes from. And so I'm going to leave you with a couple key governing principles here. You should share as little as possible. And when you're going to share data or store it somewhere, think, do I need to have this data for the work I need to carry out? This is specifically in terms of research in our clinical trial. If I'm getting a data set from Debbie Lee, do I necessarily need all the patient names or can I work with their study code? Does the person I'm sending this data to, Carrie Seek might be our monitor. Does she need full read and write access, or can she get by with just a spreadsheet or data service? And can I accomplish the same amount with less data? Do I necessarily need 40 variables when I can get by with 30? So those are just some things to keep in mind when you're working with data. The other thing is don't share it through inappropriate channels. So the famous example from around here is one of the med students took a picture of the patient discharge log behind them, actually posted on social media because they were like first day in the OR or something like that. So you should never, in any case, put sensitive data on social media. And these are not unencryption methods. These are methods to encrypt your data. You can send different classes of information and in, with liquid file, please refer to the guidelines there. And then with BitLocker to encrypt your data at rest. So don't share the data if it's sensitive through unencrypted methods. With that, I will take questions. A couple resources. The Bird Corps, and specifically the bioinformatics group, is always here to help point you in the right direction or answer simple questions when it comes to information security. Please do not hesitate to reach out. Our generic vanity email, which goes to most of the team, is just WVCTSI birdcorps@hsc.w.edu. And with that, I'll take questions and then we'll play a quick Kahoot.
And feel free if you want to submit your question anonymously to me via the chat, or feel free to take yourself off of mute as well and to talk directly to us. Sorry.
While I'm getting our Kahoot pulled up.
Are you going to test us on what you just taught us, Tyler?
Absolutely.
Oh, man.
So like always, you do not have to put in your exact name if you don't want to. You can put in your favorite book character, but something that's pretty unique so you know who you are. For those of you who aren't familiar, you can either go to www.kahoot.it, not .com, and put in that game pin, or you can scan that QR code with your phone. And we're just going to do 10 quick questions to help us review really quick. I agree. TGIF. Give everybody a couple more seconds. I'll keep an eye on the chat, or Debbie Lee, if you can help me keep an eye on the chat in case anybody's stuck or panicking.
Yeah, I got the chat time for you.
Okay, last call. So here we go. Your answer pad is your phone. Here's our info security questions. Question 1, what is the federal law that governs healthcare information and how we use it? Very good. Got 2 with the distractor. It is HIPAA with 2 A's, the accountability. Which of these is not an identifier, one of the classic 18? Correct. A lab value on its own would not be considered an identifier. What can I not leave on my desk under the clean desk policy? Very good. You probably shouldn't leave your week-old lunch on your desk, but under the clean desk policy, do not leave PHI. What type of data set has some, but not all of its identifiers removed? Good. So a limited data set has some of the identifier removed. The coded data set is when we translate those identifiers to something else. What type of data set has all of its identifiers removed? I'll give folks the coded data set, but I was looking for HIPAA safe harbor here. So HIPAA safe harbor is when we have all of the identifiers removed. A coded data set could have all of its identifiers removed, but we've added back in that unique ID to identify each person. Where does PHI, protected health information, come from? Very good. Our PHI comes directly from the medical record. What's the main difference between PHI and RHI? Very good. Similar to last question, the main difference between RHI and PHI is where the data comes from. Remember that PHI is coming directly from the medical record. And that's where I'd point you all back to that OHRP template, which Debbie Lee will send out with the different categories based on its source. True or false? It doesn't matter how I share protected data. Very good. It does matter how we share protected data. Please don't send your study binders via carrier pigeon. True or false? I should lock my computer in one way or another when I step away. Yes, for heaven's sake, please lock your computer. Last one, which is not a de-identification method. Very good. Clearwater method is not a de-identification method. That is something I just made up. Expert determination is the less popular or least popular option, but it still can be done. Congrats, not you. Good job, Yoo-hoo. And number one goes to TMR. With that, I would like to thank you guys for attending. I will hang out for the next little bit to answer questions if you guys have any. Debbie Lee, do you have anything else for these folks?
Yes, thank you so much, Tyler, for that. And thank you for the Kahoot at the end. Obviously, even though I should know the answers, I'm not fast enough to push the buttons on my phone. So just two upcoming things. I don't know why I did this to myself, but that's okay. Next Thursday, June 27th, I am doing our 3-hour training session with clinical trials research training from start to finish. So if you have any, maybe a new hire or someone that needs just a refresher, or you think would be a good candidate for that training, feel free just to email me and I'll get that invite out to you. The other thing, that same day on June 27th, this session will be from 2 to 3. We are partnering with iScore RC for their seminar series, and it's best practices in working with contract research organizations. So we actually have 3 people that are sitting on our panel, and they're going to provide us some information from their career paths, how to stay relevant to CROs, and things like that. So for either of those, you can just email me and I will gladly get the invite out to you for those. All right, any further questions or comments for our presenter today?
I dropped the Bird Core email in chat for anybody that needs it.
Perfect. And as always, I will follow up with the CE form. I'm going to be honest, I'm logging off after this today. So I will do that first thing on Monday, and also get the slides and the sign-in sheet for those that need ACRP or SOCRA. So with that, thank you all for joining us